Thank you, Maya, for the introduction. My name is Verena Schreiber, and I am a PD pod at Miami, at Nicholas Children's Hospital. My expertise is actually hip deformities and then neuromuscular conditions and trauma. And so today, first one, I will be talking about SCFEs a little bit because I think there's still a lot of debate on what to do. And depending on which part of the world you're in, these are treated a little bit differently. So we're going to go over this. We're going to show a couple of cases, and I think it's going to be a good discussion. So I don't have any disclosures. So just a quick overview, the pathophysiology of this. So what a SCFE actually is, or what it does, basically, it means that the femoral neck moves anterior and superior to the head, while the epiphysis remains in the acetabulum posterior and inferior to the neck. So that means that the distal fragment is inverus in the coronal plane, it's an extension in the sagittal plane, and an external rotation in the axial plane. So that's what it looks like in a pretty severe slip. Now, the treatment basically is depending on the severity of the SCFE, and the severity of the SCFE is directly related to the duration of symptoms. So goals of the treatment are to prevent progression while avoiding complications. The treatment of unstable SCFE still remains controversial. And that's what we're going to talk about a little bit more tonight. One second. So the gold standard, I would say, in the US and in a lot of other parts of the world is the single screw fixation. The advantage of that is it's a percutaneous placement. It has minimal soft tissue disruption. It really has a high success and patient satisfaction rate, and it has a low incidence of slip progression, osteonecrosis, and chondrolysis. What I normally do for these when I do single screw, so it's dealer's choice if you do these on a fracture table versus a flat Jackson. I like the flat Jackson better because I feel like I have better control just like from my imaging. The optimal pin position is what you do is you basically draw a line around the femoral neck, and then you want to actually decide what your slip angle is. And if you draw that line, I'm going to show it here. If you draw that line all the way down along the femoral neck, like if your slip angle is basically 30 degrees, you would basically move that line just like 30 degrees up, and that will be your starting point for your SCFE. So you want to start a little bit anterior, and then advance that screw, which should be a fully threaded screw, because removing a partially threaded screw down a line is just like a horrible thing to do, and it's really hard to do. And you want to advance that until you are around like 4 to 5 threads in the epiphysis. There are studies that have shown that the slip progression is approximately 40% in hips with less than 5 threads versus 0% in hips with more than 5 threads. Now, one test that I always do when I'm done with my fixation is I do the so-called approach and withdrawal technique. So I do a live fluoro, and I move the femur basically around, and I want to see that the screw head is actually approaching and withdrawing to make sure that the screw head is really not in the joint. And then also to make sure that you're not in the capsule, that your screw is not too anterior. Number one, you want to start just like lateral or just right around the level of the intertrochanteric line. And you want to get a false profile or a 45 degree oblique view just to make sure that you're not impinging with your screw. This, for instance, is an example of a 12-year-old male presenting with a limp. He had left groin pain, thigh pain, and knee pain for several weeks. And this is really important. A lot of these SCFE kids may not present with hip pain initially. They may come in with knee pain and are being worked up for knee pain. And a lot of times the hip is being neglected, and then it's actually a slip and not the knee that is a primary culprit. So just like a little advice is always like, if you have a kiddo that comes in with knee pain, always do a good hip exam, and this is important for the residents. So this kiddo was actually referred from an outside provider, and you see, like here, when you look at Klein's line, there's a slip on the left side. Definitely, when you draw the line up the femoral neck, there's really not much of a overlap with the epiphysis. So what's the plan for this kiddo? So this kiddo was ambulating, pain for several weeks. So this is an acute slip that is stable. That means the kid is able to ambulate without any assistive devices. So this kid gets an in-situ pinning, right? And this is like very straightforward. Again, like this, if you criticize this was not my case. Screws maybe a little bit bent, and you could have advanced up like a couple of more threads here, right? Just that we get those 4 or 5 screws across the joint here. And then the other thing is also when you pin, it's a prophylactic pinning, right? So the risk of developing a contralateral slip is over 2,000 times higher than the risk of an actual initial slip. So what are the arguments for prophylactic pinning? Well, number one, if you have a high rate of contralateral slips, and usually kids that are under 10 and have slips due to endocrine factors, I usually always prophylactically pin on the other side. You have an increased risk of a contralateral slip if your triradiate cartilage is still open. And so that's also something to consider. And it's actually low complication risk with modern pinning. However, there are arguments against it. So number one is it's not warranted if you feel like you can detect a slip early with close follow-up. And there is always the risk of surgery, right? If you're doing a risk on the surgery on the other side, there is a risk that you can cause technically an iatrogenic injury. So, but then what happens with these kids? So like, oh, we're pinning everything in situ, even the severe slips. But what happens? Like these kids do come back with some post-traumatic deformity, unfortunately. Not all of them, but the severe slips a lot of times do. And then, so what are options then? So there is a role for arthroscopic procedures or the open osteochondroplasty. I'm not an arthroscopist, so usually I do surgical dislocations because I feel more comfortable with that. But in the hand of a good arthroscopist, it is reasonable to do these mild deformities via scope. So the reason for this is like to decrease in future cartilage labor and damage. And then osteotomies of the femur are being done to improve range of motion and decrease FAI. It is usually, it's found to be that this is a lower risk of AVN than the initial correction of deformity through the open approach. And this is especially true in an unstable SCFE. However, you still have the risk of AVN, right? This is not off the table just because you're waiting and you correct in the deformity. And basically what you do is you treat a deformity with most likely further deformity. But the overall outcome is actually fairly good. So the less risky option, and Francois is going to talk about the open reduction in acute settings, is the Imhäuser osteotomy, the endotrochanteric osteotomy. Is that a less risky option? So you usually would treat your SCFE per usual care, like an in-situ pinning, and then you deal with the deformity later. So that Imhäuser endotrochanteric osteotomy is basically being done by excising an anterolateral wedge, and then you create flexion, valgus, and internal rotation. And then it's dealer's choice if you want to use a blade plate or a proximal femoral locking plate. I'm more of a blade plate person, but I've done it both ways. And this is really just like whatever you feel comfortable with. The pros of this are really that it's simpler to perform than a surgical hip dislocation. However, in a lot of cases, you have to do it in combination with an SHD just to treat the deformity that you find intra-articularly. It has a low risk of AVN. It corrects the deformity. And as I said, you can add an osteoplasty to address the residual cam deformity. The results here, there were multiple studies with favorable long-term outcomes. As you can see here, the last one was by Trisolino and JPO, and they did 39-year follow-up, and 69% of these kids actually avoided a total hip. The recent studies showed that the ITO and the osteochondroplasty, that last by Bali in 2014, 20 hips with ITO neck osteoplasty, did better NIH scores for osteoplasty versus not doing an osteoplasty. So this is a case, 15-year-old female, status post in-situ pinning at an outside institution. She came into the office. She was no longer able to sit in a seated position. She was unable to really bend forward. She had left hip pain. On a physical exam, was walking with a Trendelenburg. Hip flexion was to 60 degrees, her internal rotation to -10, and her external rotation to 30 degrees. She had pain with flexion, external and internal rotation. The right hip in comparison had a hip at flexion to 90 degrees and slightly better range of motion, but her right hip was not bothering her. So this is her imaging. I do get 3D recons on these kids because I think they're very helpful for my post-preoperative planning. And as you can see here, I didn't put the whole CT in here, but you see like there's definitely an obvious deformity bilaterally, more so on the left than on the right. And she had actually a big cam deformity. So what's the plan for this girl now, right? So she had in-situ pinning done. So this kiddo ended up with removal of hardware and then a surgical dislocation with an osteochondroplasty, and then the Imhäuser osteotomy, basically flexion and derotation osteotomy. And post-operatively, she had a minimal left residual Trendelenburg. She had symmetric hip flexion, and her internal rotation was a little bit improved. Her external rotation was better, and she was painless range of motion. And then she was lost to follow-up 8 months after surgery. So I'm hoping that she's doing well. Otherwise, I would have thought she would have come back, or she just hates us. But this is what we do. And this is another one, 15-year-old male, 6 months status post in-situ pinning, also an outside hospital. Hip flexion here was also limited, and internal rotation was also limited. So This kiddo also needed something done. So this kiddo got a surgical dislocation with a head neck osteochondroplasty. So no intertrochanteric osteotomy. In this case, this was really just like more like a cam deformity, which could be treated nicely. Again, if you're a good arthroscopist, I'm sure there's a good role for doing a scope on this one. I just don't do scopes, and I just feel more comfortable with the open approach here. The follow-up is really important. So regardless of the fixation method, all SCFE patients need to be followed at least to skeletal maturity. You got to make sure that you have physeal closure of both hips to confirm that there's no further slip of the contralateral side. Mild slips may do well. It only requires short-term follow-up after skeletal maturity. However, some evidence supports long-term follow-up. The moderate to severe slips, especially the unstable ones, there's good evidence that they should be followed past skeletal maturity. You need to monitor them for AVN, and they need most likely further procedures to preserve the hip function. That's not always like necessary, but the majority of them will need that. And then we'll talk about the salvage procedure. So this is basically like when everything fails, like total hips, obviously. Historically thought they have a better short-term function and less risk to other joints with increased revision and failure rates in young patients. And the new studies actually have shown that they have good survivorship, and the complication rates in young adults are comparable to adult arthroplasty. And this is more like the arthrodesis, more like really like a second line salvage procedure. Like I've never done one. Originally it was thought to have good long-term durability, but there's a high complication rate once you actually convert them to a total hip when they're adults. Obviously, the function is very limited and has a high load on the adjacent joints. Especially with bilateral SCFEs, you have increased stress on the contralateral hip, and this is usually like the second choice for really a select group of patients. So I want to thank you, and I'm going to stop sharing my screen now, and I'm going to turn it over to Francois.